Hey guys, welcome back. This is Dr. Marwah and today we shall be discussing some questions from QBank 3.0. Let's get started with the very first one today without wasting our time, and the objective of the discussion is to check your response time. I would like you to comment in the chat box below so that we can see in how much seconds are you able to get to the correct answer. In the first one, we are talking about a 20-year-old victim of a car crash who was wheeled into the emergency room with a low blood pressure, thready pulse and an elevated non-pulsatile JVP. And you very well know the fact that this is going to be a very key word because this would help you know that the patient is actually going into an obstructive shock. And non-pulsatile JVP, whenever you read, there are only two differentials that have to be kept in mind. One is superior vena cava syndrome and second is cardiac tamponade, and especially when we are talking about a car crash, cardiac tamponade comes in the mind. Now, crepitus is noted over the right chest wall with fracture of ribs. So what I am presuming is that in this person, since there is a subcutaneous emphysema present, that is why the crepitus is being felt. And at the same time, the fraction of the ribs also points to the fact that there could be even tension pneumothorax. So probably in the very first line of the question, the impression of mine is that this could be a polytrauma case which has been given. The X-ray and the echo reports of this patient are shown below, and what is the correct statement for approach for the procedures done in the patient. Now, I would like to highlight that for this particular case, the X-ray and the echocardiography are more of a distraction. Though if you cast a glance, you will definitely notice absence of any vascular markings. That's very characteristic that you will encounter in a patient with tension pneumothorax. And obviously some evidence of mediastinal shift can be present. Some amount of air can be present even behind the heart. So I can say pneumomediastinum is also present in this case. So tension pneumothorax per se has been confirmed both from the findings given in the theory as well as the MCQ. And for echocardiography, you really don't need to bother because that's a distraction. I mean, there is no point or reason why you should be knowing echocardiography as a MBBS doctor. So that's more of a distraction that's incorporated. Option A says central venous catheter inserted into the femoral vein will be medial to the femoral nerve and lateral to the femoral artery. Now, this question, option number A per se, I would say is an applied aspect, or rather is testing your anatomical knowledge also. And well, as a matter of fact, I mean, a query that will come very sure will be that, sir, what is the need for putting a central catheter in the femoral vein of this guy? Why are you not putting a central catheter in the intrajugular vein? Please appreciate, if somebody is having tension pneumothorax, then putting it inside, especially if there's a subcutaneous emphysema present in the case, it becomes very difficult to put in intrajugular vein catheter, especially with subcutaneous emphysema extending up to the neck. So that's why probably the physician has decided to put it in the femoral vein. Now the anatomical aspect is very simple and straightforward. If you look at this diagrammatic representation, the point is that if you put a catheter in the femoral vein, then this catheter will be medial. The red line is the catheter. The catheter will be medial to the femoral artery as well as the femoral nerve. Whereas in option number A, it was wrongly written. I'll just show you the diagram once again. You will notice the fact that it is written the catheter will be medial to the femoral nerve and lateral to the femoral artery, whereas it should be medial to both of them. No, I just showed you the diagram. I'll just show you once again also so that you can just get a visual memory of it. You see, this is the femoral vein per se. The femoral vein is medial to both the artery as well as the nerve, which is the reason why I'll have to swap the slide anyway. Option number A will go out of the window. So let's focus on option number B. He says needle insertion landmark for pericardiocentesis is immediately below to the right of the xiphisternum, between the xiphisternum and the right costal margin. Now here the problem is with the wordings, because when you're doing a pericardiocentesis, everybody knows that you will have a xiphisternal approach. But the problem in this particular statement is that you are approaching it to the right of the xiphisternum. Rather, we should be approaching it from the left of the xiphisternum. In fact, I'll show you an image once again so that this becomes a memory for you and you are able to rule out option number B also. You can see that you are obviously introducing the syringe from the right. But look at where it is entering in the xiphisternal area. It is entering on the left side of the subcostal zone. It is not on the right of the subcostal. In the MCQ, it was given on the right of the subcostal area. No, it is the left side where you are introducing it from the right. But you see, the drainage catheter has to go in the fashion that it is shown. I mean, I have shown the approach. You are trying to hit the middle of the left clavicle per se. Obviously, the procedure is echocardiography guided. No issues with that. But the problem with the second statement, I'll again toggle the slide, will be that it is wrongly written in the option number beta, that the insertion site is between the xiphisternum and the right costal margin. That's the wrong statement. It should be the left costal margin. Now let's look at C versus D, and I'm very sure by this time most of you have been able to come to the final diagnosis. The needle compression or tension pneumothorax is going to be put by putting a needle in second intercostal space. That's okay. In mid axillary line, you very well know it's not mid axillary, it's a mid clavicular line. So my point is that you can easily rule out option number A, B and C by reading out the options. The point is it takes some time, so you need to have patience to read the statements very carefully, because there's a possibility, like in option number C, initial part of the statement was fine, but the lateral part of the statement is definitely wrong. Let's look at D, which is the answer to this question as well. So I'll just mark that as an answer by exclusion. It says diagnostic and therapeutic abdominal paracentesis can be done or performed 2 centimeter below the umbilicus. Is that correct statement? Well, a lot of you might be saying, sir, when you describe paracentesis, you described it in, I would say, lateral to the umbilicus. Yes, I agree to that, but in 10 societies, you can even do it in the midline just below the umbilicus as well. So I'll just show you a slide so that you're more comfortable. These are the usual slides. No? The usual sites where you would be going in for paracentesis would be obviously lateral, because you don't want to injure this artery, that is the inferior epigastric artery, which in this case can definitely be injured. So you want to be lateral to that. Well, the markings are obviously from the anterior superior iliac spine. So you have to go up little medial and little superior for the anterior superior iliac spine. But in emergency, you can even be going right below the umbilicus about 2 centimeter. That would be in especially cases of tensitis. So these are 3 sites for abdominal paracentesis per se. And well, in this case, it was a case of polytrauma. No? Even the abdominal wall bruising was noted. You can see in the third line it is written the patient was having abdominal wall bruising. So there's a possibility that even in polytrauma, even his visceral organs could have been injured. The question is mainly based on your reading skills per se. The correct answer to this question is delta, and I'm very sure most of you have been able to come out to the right option per se. In case you missed it out, no issues. It's just that you have to do these questions on a regular basis, and with the kind of the negative environment outside, especially with respect to the problems that we doctors are facing both at handling the COVID situation plus postponement of exams. I know that the getting the mental equilibrium and getting that right frame of mind is a little difficult, but we will have to persist. That's the important word for today, guys. We will have to persist so that we are able to overcome these odds and come out with flying colors. The answer, as I've explained to question number 1, is delta. So let's focus on the second question for today. A 25-year-old guy is having recurrent flank pain episodes and severe constipation, and this person was found to be having renal stones. The type of stone was found to be ammonium urate. I mean, that's the composition, and I would rate this as one of the easy questions for today. He's saying which of the following is responsible for this type of kidney stones. You can easily rule out option number A, myeloproliferative disorder, because this will contribute to development of uric acid stones, whereas in the question it is given ammonium urate. Option number B says hyperparathyroidism. Now, hyperparathyroidism can be having constipation, and hyperparathyroidism can also be contributing to recurrent episodes of stones. But the problem why hyperparathyroidism is not the answer to this question is because the type of stones that would be formed there will be mainly calcium phosphate stones. It's because calcium is elevated, and calcium and phosphate, if their multiplication product goes in excess of 55, then these two can definitely chelate with each other. I mean, that's the reason why I have explained that both in hyper as well as in hypoparathyroidism, because in hyperparathyroidism calcium will go up, in hypoparathyroidism it is phosphate that will go up, and the two will chelate and will result in formation of kidney stones in a person. So yes, I agree that constipation could be a distractor in this question, and you might start thinking it could be hypercalcemia, because hypercalcemia also has constipation. But in this person, because he has given the composition as ammonium urate, therefore, you very well know that ammonium urate stones are the ones which are seen with laxative abuse. And why the answer is not renal tubular acidosis is because in RT again, the type of kidney stones that are usually formed are calcium oxalate stones. In fact, one of the leading causes of calcium oxalate stone is idiopathic hypercalciuria. Then another important one that is asked in exam is what is mentioned here, renal tubular acidosis. The answer to this question is C, and I know the usual query from most of you, I know that a lot of you would have got this right, will be that why is laxative usage contributing to ammonium urate stones. So let's delve into this in the next 30 seconds and get over with this question. You see, whenever you are having excess use of laxatives, then there would be depletion of water from the body, depletion of salt from the body, And I mean, multiple electrolyte deficiencies are anyway seen in people who are having laxative abuse. My point is that these patients will be having depletion of both electrolytes as well as water from the body, and therefore these patients will be having a state of intracellular acidosis. I repeat the fact once again, laxative abuse causes loss of water from the body substantial enough in abuse status to cause intracellular acidosis, and the rest of the things will fall into place. You see, the basic function of the kidney is to maintain electron neutrality. I've used the short form EN, electron neutrality. So if protons in the body will be more, listen to my words very carefully, if the protons in the body will be more, these protons will be lost by the kidney. Therefore, you will be having increased concentration of hydrogen ions in the urine of this patient, and these hydrogen ions will result in following thing. One, they will bind with ammonia, and therefore binding of hydrogen ions with ammonia will result in formation of ammonium. And second, the hydrogen ions will also cause crystallization of uric acid. Please remember that uric acid is an acid. The acidic pH of the urine will cause crystallization of uric acid simultaneously, and the two will then chelate to form ammonium urate stones. I have just tried to simplify what is mentioned in journals. Why does laxative results or laxative abuse results in formation of stones? The logic is there is an intracellular acidotic state due to depletion of water electrolytes from the body, and because the kidney wants to maintain the electroneutrality component, therefore there is loss of hydrogen ions that will trigger crystallization of uric acid, along with, because hydrogen ions are not excreted per se, they are always excreted bound to ammonia. So it is ammonium ions plus uric acid, and that is responsible for this peculiar composition that is called as ammonium urate stones. And in this question, when I was discussing it with a couple of students initially, I found that couple of people in the database had answered this as hyperparathyroidism, because we do get constipation and hyperparathyroidism also. But then the composition of stones will definitely be different, and that is how you will be able to pick up. I mean, between two close choices B and C, the correct answer to this question is option number C. Let's move on to the third one, and I'm happy that a lot of you got this correct. Let's see your response for this one. Fastest finger first, like that way. A 25-year-old obese person has experienced an excruciating headache followed by loss of consciousness. So you are definitely thinking in terms of a CNS event, and is rushed to the emergency room where the GCS is definitely low. Well, it has not reached the level of coma, I would say, but then definitely at least the GCS of this patient is alarmingly low, and his right pupil is showing sluggish reaction to light. So there is definitely a possible CNS bleed in this guy, which is involving the oculomotor nerve. The NCCT head of this patient is performed, and that's the key. I mean, that's the step one. You definitely can see presence of blood in the this presence of blood is not at the moment in the area where I put the arrow. That is not the Sylvian fissure. This is the interhemispheric fissure. This is the Sylvian fissure where the blood is present, and in this condition even some evidence of blood is found in the ventricles also. So this particular person is having a definitive subarachnoid hemorrhage with a intraventricular extension. I repeat the statement again. This particular individual who has had a sudden loss of consciousness is probably having a AV malformation in the brain, due to which you can see blood in the following areas. You can see the blood in the interhemispheric fissure where I'm putting 1. You can put blood in the Sylvian fissure on the left hand side. That's why probably the manifestations were coming up due to loss of consciousness, and there's a IVH also in the patient. Now the question says, which of the following is true about this condition? Option A says peak incidence of vasospasm is on day 4. Well, this is what you need to read up. Vasospasm takes time to develop. Initially there's a bleed, then there is a protective vasospasm. The peak incidence of vasospasm is usually around about the 6th or the 7th day. So I mean, option number A is a wrong statement. Why? Because this peak does not occur immediately. If this peak will occur, I mean, the point is, what's going to happen if the vasospasm will occur immediately? There will be cerebral infarction. I repeat my fact, there was a bursting of a aneurysm, there is a bleed present. Now if the body will exhibit an immediate vasoconstriction, then there will be cerebral ischemia and the person would die immediately. Now in the body, obviously the body will try to protect the damage, but at the same time it occurs gradually. So the peak of vasospasm is usually around about the 7th day. That's why option number A is wrong. Let's look at B. It says the clipping and the coiling are equally effective options in terms of neurological outcome. One, I want to highlight the fact that when it comes to the clipping procedure per se, that will be requiring a craniotomy. Whereas coiling is relatively a same day, I mean, you can discharge the patient on the same day because you are having an endovascular approach, and it has been documented that coiling per se is always superior as compared to the clipping component. So earlier we were using an aneurysmal clip for management of an unruptured berry, but currently it has been documented that coiling, because not only is it gonna be faster, not only are you gonna have a earlier discharge in the patient, but even from the perspective of helping in preventing of the bursting of the aneurysm, the coiling part has been provided to be superior. And one of the reasons for that I can say is that that's a platinum wire inside the berry aneurysm. It helps in organizing the wall. It helps in formation of a thrombus initially, and then there's a definitive fibrosis in the wall of the aneurysm, so the chances of rupture are relatively lesser. So problem with option number B is this word equally effective. It's not equally effective. Coiling is superior as compared to clipping. Option C says triple H therapy is equally efficacious as nimodipine. Well, when we did not have nimodipine, triple H therapy was used. And what is triple H therapy? We were deliberately keeping the BP on the higher side. Why? Because you want to maintain the brain perfusion. And how were you achieving that? You were achieving that by causing hypervolemia. So we used to rush lots of fluid into the body of this patient, and this will also contribute to hemodilution. So the older concept behind management of subrectal hemorrhage, let me say 20 years ago, was keep the BP on the higher side, try to maintain cerebral perfusion pressure. I hope you remember that formula. CPP is a difference of MAP minus ICP. So earlier the objective was that if you keep the MAP on the higher side, you definitely can maintain the cerebral perfusion. But then this is a primitive approach. It's not equi-efficacious. So that's why I'm ruling out option number C. D says sets a MAP target of 90 millimeter to maintain effective cerebral perfusion or circulation. This looks like a reasonable statement. The correct answer to this question is option number delta, and because of very closely matching terminologies, you did have to apply a bit of logic for this particular question. As compared to question number 2, I would say question number 3 had higher chances of errors. I mean, when I check in the database, I am finding that most people are able to read this and get the answer very fast in matter of 40-45 seconds. But when it comes to 3, the error margin is relatively higher. So you just need to keep a watch on the language of the question. You see, most of us, we are so involved in that I should read extra, I should do this, I should do this, or I should have 10 different sources. I would just request you to keep things simple, guys. Use one source and read the questions very carefully. I mean, whenever you are attempting the questions, no, you don't have to have a casual approach of lying back, sit on a table and a chair and give a test the way it should be. And you will notice the more you practice the questions, now you will pick up those silly things that we tend to miss. And those silly things are the wordings only. Otherwise, I would say that all of you are brilliant chaps. I mean, you have come so far, endured so much. You are definitely gonna rock the scene subsequently as well. But yeah, at this moment, I am finding a lot of guys losing focus and losing concentration. So my humble request is be persistent. Be persistent. That's the only message why I'm conducting this session, so that I can get you into that right frame of mind, the same aggression, that the same mental aggression that you guys have. I want you to get in the same frame of mind once again, so that you can just get going and get over with this. Coming to question number 4 for today, this is about a 50-year-old obese woman who's admitted with complaints of severe epigastric pain and vomiting episodes. The attendant has revealed that even few sips of water are not being retained by the patient. So we need to understand that the vomiting component is fairly severe, and her upper GI endoscopy is showing some antral gastritis, and the scope could not be pushed further into the duodenum. So he has given you evidence of the fact that there could be a possible gastric outlet obstruction present in the patient. Age group of the patient is around about 50 years of age, so we need to consider whether it could be a carcinoma present. But anyway, I mean, there's no history given suggestive of a cancer per se. There's no mention of any weight loss. There's no previous mention of any vomiting episodes. It's an emergency situation where a gastric outlet obstruction is described, and well, the CT abdomen of this patient is showing a 5 centimeter gallstone that is exerting a mass effect on the pylorus. The question says which of the following is correct about the case. Let's look at option number A, Mirizi syndrome. You see, the problem with Mirizi syndrome is that there's a stone stuck in the infundibulum or in the Hartmann pouch. And let's look at the problem. You see, if I just zoom into the slide, you can notice that in Mirizi syndrome, the stone is impacted in the cystic duct of the patient, and this will cause pressure on the common hepatic duct. And therefore, one very prominent feature that can develop in Mirizi syndrome is jaundice in the patient. Whereas in the question, if you read the language of the question once again, there is no mention per se of any jaundice present, which is why I'm ruling out option number A. I repeat the fact once again, Mersey syndrome, where there would be a stone retained in the cystic duct, the pressure on the common hepatic duct will cause a biliary outflow obstruction, so that can trigger jaundice in the person to develop, and therefore Mersey syndrome is being ruled out at the moment. Option number B says Burweit syndrome. Now let's understand what Burweit syndrome is all about. Burweit syndrome would be characterized by a gallstone that is going into the duodenum. You can see in this particular image or the handout, you can see that the gallbladder is having a stone which can erode into the duodenum, and this stone can be big enough to actually contribute to a gastric outlet obstruction. So this looks like the answer to this question, and mainly the concept is in an emergency situation when you are having a gastric outlet obstruction. I repeat the fact once again, if you're having features of GOO in an emergency scenario, then two things must always be kept in mind. One is stomach volvulus, and second is gonna be what we are talking at the moment, that's a gallstone which could have actually eroded, it's contributed to a choledocho, then a subsequent a duodenal fistula. You see, whenever you read about the term Burweit syndrome, you always know the fact that there's a stone eroding into the duodenum of the patient, and obviously the stone can progress forward towards the ileum also. But at the moment, what it is causing is, this is the stomach of the patient, it is causing a gastric outlet obstruction which is responsible for manifestations of this patient. And well, why it can't be stomach volvulus? In stomach volvulus, then the CT abdomen will not show any finding of a gallstone per se. I'm ruling out stomach volvulus. You see, there can be mesenterico-axial, you very well know that from surgery. It can be organoaxial volvulus, it can be mesenterico-axial. You see, if the stomach will rotate from bottom upwards, it is mesenterico-axial, just putting an M for that. If it's going like this, we call it organoaxial volvulus. Stomach volvulus per se should always be having presence of a Borchardt triad. In Borchardt triad, he'll always describe a NG tube not being navigated forwards. But in this particular question, there was no mention of any NG tube not being able to navigate forwards. In fact, NG tube will not even go in the stomach when the stomach is folded on its axis. In this case, when the I would say the gastroenterologist was doing upper GI endoscopy, he could send the scope into the stomach. You see, in stomach volvulus, the scope will not even go into the stomach. Here, the problem is not in the stomach, it is after the stomach. So that is why it is written. I mean, the key word for this question that is highlighted is that the scope could not be navigated into the duodenum. That's the key word that you actually need to pick up and understand. There's a gastric outlet obstruction which narrows down to the diagnosis of beta. That would be a Burweit syndrome. And well, why would it not be cholecystodocal fistula? In case it was a cholecystocoledocal fistula, then the stone would go this way. Now the stone will erode into the biliary. I mean, this large stone will erode into the biliary pathway. Again, it can contribute to features of cholangitis. It will again contribute to features of jaundice in the patient. But whenever you would be having a whenever you are having option number C coming in the picture, it would contribute to features of cholangitis in the person subsequently. You would not have this classical statement that I highlighted, that the scope could not be navigated into the duodenum. I mean, that gastric outlet obstruction that is occurring is primarily the stone has eroded from the gallbladder into the duodenum, which is contributing to these manifestations. And when you will read the literature of Burweit syndrome from surgery, you will also notice that there have been cases reported where the gallstone, the large one, can erode even into the stomach of the patient. I mean, that looks very shocking and very surprising, but this has been documented, stone eroding into the stomach of the patient as well, though relatively, I would say, I mean, on a comparison basis, duodenum versus the stomach, the duodenum part is relatively more common. Answer to question number 4 is beta, guys. This was a question on acute abdomen, and I put this question not that I want to discuss surgery with you. I will let the surgeon do that. I put up that question only to just, you know, get you into that groove that your brain should be able to jump from a medicine oriented question to a surgery based question. Let's not have that orientation in our mind that, okay, this particular subject I'll be, you know, I mean, once you go with that mindset that one particular subject I'm good at, so only those questions I will do, I mean, that will rather hamper your progress. I want you to have a broader perspective. I mean, since you guys are having the, I would say, the advantage of time at your disposal, though it's not a good time, I agree to that. But since you're having advantage of time at your at your disposal, so I would like you to invest time into questions of especially emergency medicine. Like acute abdomen, you need to keep all the differentials in your mind. You need to think as an emergency physician there, not have a view that okay, it's a medicine question versus a surgery question, because once you have a bird's eye view, an overall holistic approach, that's what they are expecting in the exam, that you are looking at the case from a bird's eye perspective, bird's eye view perspective, or overall domain of the question is being evaluated by you. So you yourself will be able to rather see that your performance will go up once you think from that particular mindset. And I'm sure most of you are doing that, but I just wanted you once again to get into the groove once again, as I'm saying repeatedly in this discussion, because my inbox is full of one simple message: sir, I'm not able to focus. So switch off your social media. That's the only thing I can say, because in on social media so many people will be saying so many things, so obviously there are bound to be distractions. We're done with this question, and yeah, one more detail that I want to highlight for this is I want you to read Burwett syndrome. I want you to read about Rigler's triad, which would be three things coming up. That would be a dilated stomach. There would be pneumobilia, obviously, because there's a stone perforating through, and a radio opaque shadow, which is suggesting of an icteric. That is, instead of saying the word an enteric, I can just use the word ectopic gallstone. I mean, it would look a little funny, but I can say this is a unofficial term that I'm using to describe Burwett syndrome to you. Ectopic gallstone sitting outside where it should not be. I mean, sitting into the duodenum whereas it should be in the gallbladder, or maybe even in the biliary tract of the patient. So regular triad definitely comes in, and then they can definitely ask you about the surgical domain. So I'll be sharing the PDF of this. Either you can mail me directly at marwamedicine@gmail.com, or we have this Telegram group that is Top Educators. So you can search for that in Telegram, and I'll be posting the PDF there also. It's always handy, just a quick PDF, scroll through the questions, scroll, and you get an orientation. Like, this was a young patient, so he can ask you the treatment part. No, it could be a two-step question. He can ask you what's the diagnosis, what's the treatment. So in young patient, it's a one-step procedure where the surgeon will talk about enterolithotomy, cholecystectomy, and a fistula repair. Whereas if it's a high-risk candidate for surgery, it's a simple enterolithotomy which is to be done. So I don't want to get into surgery, but my only point is that when you read the language of this question of an emergency situation having a gastric outlet obstruction, your brain should be clicking not only with respect to stomach volvulus that you are very comfortable with, but you should also be comfortable with the data of Burwett syndrome. Answer to 4 is Bombay. Let's come to the fifth one, which is based on ABG. And I have, for your comfort, deliberately mentioned the values which are first to be focused. Let's read the question and then move on. And I would like you to solve it in a period of about 90 seconds or so. The question talks about a 70-year-old man who is, you can put on the timer in your mobile if you want. We are having a 70-year-old man who's admitted with severe congestive cardiac failure. So you very well know that there can be perfusion issues in the patient. I mean, when you're reading an ABG question, it is important that you start getting the clinical information, because if there's a congestive heart failure, kidney blood supply can definitely be compromised. The patient is unwell for a week and puking. I mean, that's one point that's usually neglected. Vomiting in any patient causes metabolic alkalosis. Remember that. I've taught that many times, and I've seen a lot of guys neglecting that. So always keep a watch for that. He's not taking any medication at the moment, and obviously that's why he's deteriorated. He's distressed and hyperventilating, and therefore he was started on NIV and samples were drawn. So another hint is hyperventilating. The moment you read hyperventilating, you very well know carbon dioxide washout will cause respiratory alkalosis. So this looks like a question which is probably of a mixed disorder, but let's evaluate further. The pH of the patient is 7.58, PCO2 values and bicarbonate values are given here. So I'll just toggle the slide. You can very well see here that the pH of this patient is definitely increased. So I'll first write the fact that I have been able to deduce that there is alkalosis in the patient. Now in alkalosis, there can be two reasons. Either it's a respiratory problem or a metabolic problem. In respiratory problem, carbon dioxide will be less. That is what is happening in this case. So I am definitely narrowing down to the fact that this person is having the primary problem of respiratory alkalosis. Why not a metabolic alkalosis? Because in metabolic alkalosis, the bicarbonate value should be elevated, whereas in this case, the bicarbonate value is lesser. So this is our primary change, that is respiratory alkalosis. Now let's follow the rule. In respiratory alkalosis, carbon dioxide definitely goes down. If you attended the main lecture of ABG, I have taught you that if carbon dioxide decreases by 10 points, then in acute respiratory alkalosis, the bicarbonate value should fall down by 2 milliequivalents. I repeat the fact once again. In patients who are having respiratory alkalosis, a rule of 10:2 is to be remembered, that if carbon dioxide will go down by 10 points, then bicarbonate will come down by 2 points. in this question, you can see that carbon dioxide value is reduced to 20. Let's take an average value of 40. You very well know 35 to 45. So if you take 40 as an average value of carbon dioxide, in this patient, the carbon dioxide value has decreased by 20 points. Average is 40, it is now only 20, so it has decreased by 20 points. So if carbon dioxide will decrease by 20 points, then bicarbonate should decrease by approximately 4 milliequivalents. If you take average of bicarbonate as 24, you very well know the range of bicarbonate 22 to 26. If you take average as 24, then 24 minus 4 will turn out to be 20. So if the bicarbonate in this question was given to be 20, I would have said compensation is working. But in this question, you will notice that the actual value of bicarbonate is not 20, it is rather 15, which means that this is a mixed disorder. Let me repeat this step once again. So I'll cross the 90-second threshold definitely, but this is the crux of this question. You need to understand in all questions, is it a compensatory disorder that is being asked, or is it a mixed disorder that is being asked? So like in metabolic acidosis questions, you apply Winter's formula. If you not listen to the ABG discussion, my humble request is please go through that. The point is, in metabolic acidosis, we apply the Winter's formula or simple value of bicarbonate plus 15. Similarly, here you need to apply the 10:2 rule. 10:2 rule होता क्या है कि अगर कार्बन डाइऑक्साइड 10 पॉइंट गिर जाएगा तो बाइकार्ब को भी 2 पॉइंट्स गिरना है. यहाँ पे कार्बन डाइऑक्साइड पेशेंट का 40 से 20 हो गया, 20 पॉइंट्स कम हुआ, so the bicarb value should go down by 40, that is 24 minus 4. 24 is the average bicarbonate value, 22 से 26 होता है. तो अगर 20 होता, अगर इस MCQ में actual value bicarb was 20, I would have said the person is having a compensation. But because this rule is not being satisfied, this means that this person is having a mixed disorder. And what is the mixed disorder in this patient? Well, it will be metabolic acidosis. Well, why am I calling it metabolic acidosis? Because in this chap, the bicarbonate values are substantially low, and there is a clinical hint for metabolic acidosis also, because patient is having congestive cardiac failure. So in all cases of CCF, what will happen to the blood supply to the kidney? The blood supply to the kidney can dramatically reduce. You could be having even a acute kidney injury developed in this person subsequently. And whenever kidney will fail, what will happen to the person? Metabolic acidosis. Now we will calculate the anion gap for this guy also. So let's calculate the anion gap. Anion gap is positive minus negative charges. In positive charges, you will take only sodium, that will be 130, and then you will subtract from this the value of bicarbonate as well as the value of chloride. Bicarbonate value is given to be 15, chloride is really very low, 75. So if you look at this mathematically, this would be 130 minus I would say 90, this will work out to 40. So I very well know patient is having high anion gap metabolic acidosis. So at this juncture, when you are reading the options of this question, you very well can rule out two options right away. Option number B is not the answer to this question. Option number especially B can be ruled out because we are not having a respiratory acidosis, we are having a respiratory alkalosis, so we are left with the remaining ones. And I am also ruling out option number D here, nagma, because this person is having an anion gap of 40. That's much higher than the range of, I mean, anion gap would be in the range of about 3 to 12 milliequivalents, right? This is much higher. So one thing is very sure, this person is having a high anion gap metabolic acidosis. So you can comment in the chat box, guys, is it A or is it C? I have worked out respiratory alkalosis before you because he is hyperventilating. It's a mixed disorder because the rule is not being satisfied, and simultaneously in this gap we are also having a high anion gap as well. Now we need to work out, is it gonna be a triple acid based disorder, right? Why triple base acid disorder? Because there could be three things occurring in the person which could actually result in problems for you for diagnosis. So whenever you are having a mixed approach, I want you to also go in for the anion gap of this patient is definitely increased. We have worked out this chap is having hagma. But before I come to the final interpretation, my request to you for discussing this question is to also teach you the concept of anion gap. Now, when you look at the textbook, anion gap will be written as change in the value of a delta gap per se. I mean, anion gap you very well know. Delta gap is the change in the anion gap by the change in the value of bicarbonate. But let's just apply this. The formula here will be, the change in the anion gap will be whatever is the anion gap calculated, that is 40 minus upper limit of 12, that's the range. And bicarbonate you need to subtract from 24, that's the average value of bicarbonate. So when you look at this from the mathematical domain, the value will turn out to be, let me just do some mathematics before you. The mathematical component 40 minus 12 will work out to be something, I'm bad at mathematics, I'll say. The numerator will turn out to be 28, denominator will be something in the range of 9. So this looks like a value of 3. Now, what do you mean by delta gap of 3? The interpretation is as follows, and that's the important point that I want you to remember for today. In fact, this last MCQ that I'm discussing is of a triple acid-base disorder. You need to remember this information that is currently flashing on your screen. If the delta gap or the delta ratio is less than 0.4, then it's a pure normal ununcapped metabolic acidosis. You will notice that if a person is having a combination of hagma and nagma, it is between the range of 0.4 to 0.8. In our case, what has happened in this multiple choice question is that the value is turning out to be more than 2. This means that this person is having definitely a hagma, no doubt about it, but there is a metabolic alkalosis component also. Why? Because the guy was puking. The correct answer for this particular question, because the delta ratio has turned out to be more than 2, I just did some basic mathematics, and anyway, once you get the PDF of this, you will be, you can see this, or you can just take a snapshot of these calculations, and you can do these by yourself also. So you very well know that the correct answer for this question is not option number C, as couple of guys commented also, and a couple of guys, I mean, in the QBank also, when they attempted that, I mean, they tended to answer this as C. Please remember, this is a triple acid-base disorder. Slightly a difficult question towards the end of this discussion, but I deliberately put this up so that I want you to get a habit of actually interpreting the delta gap in every question where there is a mixed disorder. You need to calculate amine gap in all questions by default. You need to calculate the delta gap as well. It will take a bit of mathematical practice on your part, but just try to deploy this and you will be able to get some very surprising results. And a lot of you might be saying, sir, towards the end of this discussion, you gave a question which was deliberately made difficult. Can't you simplify it? Yes, man, I can simplify it. You don't need to go into all this mathematical, I would say, information. Just focus on the words congestive cardiac failure. That means renal perfusion is compromised. Anybody is having severe CCF admitted, that means he's having acute CHF. That means the fact that his kidneys will definitely be compromised. I mean, or you know very well that in CCF kidney injuries can occur. If the person is puking, metabolic alkalosis, and hyperventilation is respiratory alkalosis. So you very well know the three things which are coming up together. I repeat that again. There's a metabolic acidosis coming up. Why? Because kidneys are getting shut down. Metabolic alkalosis due to the vomiting component, hyperventilation will cause respiratory alkalosis. So the moment you read this question, when there's a lot of information given, you need to understand there's something fishy, and then you obviously need to get into a bit of mathematics and you can work out the diagnosis of this question. The answer to this question is option number A, and I thank you for your patience and hearing me out. I know these are difficult times for all of us, and with all the negative information about deaths and everything that comes in, and whatever the government is doing with us, I mean, it results in people tending to lose focus. But then, man, you are the cream, as I say, I'll just say it one more time. You guys are the cream of the society. You guys are holding up everything. I mean, India's running on your shoulders, and or your juniors or your seniors, right? I mean, and we are their guidance mechanisms are definitely present. So all of us together are definitely handling these problems very well, and we will be able to definitely overcome this. And thank you so much for your patience and hearing me out. And instead of enjoying a video, a casual video, a high dopamine release video on YouTube, you have made all the patience to come and hear me out and discuss a ABG question. So I definitely appreciate your dedication towards this. Thank you so much, guys. Keep positive, and I'll see you again with another discussion. For the PDF, as I've highlighted, you can either mail me at Marwah Medicine Gmail or at Telegram. Top Educators is the group, and well, I'll see you again definitely. Thank you so much.